right, thank you so much. That was really excellent discussion. Now I would like to invite Dr. Coral Olazagasti from the University of Miami to the podium to discuss updates in lung cancer screening. I hope I pronounced that okay.
I'm going to bring my laptop because I'm so short that I don't think I can see over there. Good morning, everyone. Coral Olazagasti. I work for University of Miami. I do thoracic and head and neck oncology. And today I'm going to talk about my favorite topic, which is lung cancer screening. I have no disclosures in relationship to this talk. And so a little bit about what I'm hoping to talk today briefly. I want to discuss the incidence and staging of lung cancer, which I'm pretty sure we already know by now. A quick overview of the early studies of lung cancer screening, discuss the current screening guidelines, go a little bit over the rates of lung cancer screening uptake, discuss screening in never smokers, and what the future holds for lung cancer screening. And so I think we've talked about this in the past, even here today this morning, but lung cancer remains the leading cause of cancer worldwide, and that's for both men and women. The estimated cases are 235,000, and so this is pretty prevalent, and I think people nowadays are still stuck on like colon cancer and breast cancer, and they don't realize that lung cancer is pretty much the leading cause of cancer. And not only the leading cause of cancer today, but also the leading cause of cancer deaths. And I think this slide was already presented up here, but it's just good to reiterate that it's the number one killing cancer in the world for both men and women, more than breast, more than colon for women, and more than prostate and colon for men. And so obviously we all know that tobacco use is the leading cause and then the greatest risk factors for lung cancer. But it's not really the only one, and I think we also have to take into consideration other risk factors and exposures, such as radon exposures, asbestos exposure, environmental tobacco exposure, or secondhand smoking, genetics, other lung diseases, and then prior radiation to the chest area. We also have seen in recent years a trend in never smokers, which is what we want to talk briefly at the end of the talk about screening in non-smokers. And so I think everyone here knows, but it's good to just go over this incidence and staging. And so still now to this day, lung cancer is diagnosed at advanced stages in up to like 46%. That's tragic because when we see what this represents, the overall survival for cancer that's diagnosed at stage 4, the 5-year survival is 6%. And so we compare here for cancer that's locally diagnosed, which is 24%, the 5-year survival increases significantly to 60%. And I think that's something that it's important to recognize, and one of the reasons why screening is so important today. And so we can see here the 5-year trends for cancers, right? And we see that we're doing a great job, especially in breast cancer and the cancers that are diagnosed by screening. For example, colon cancer, the survival has improved. In prostate cancer has improved to almost 100%, and even cervical cancer. But the same cannot be said, unfortunately, for lung cancer. We're pretty stuck at a 5-year overall survival of about 20%. And so I think this is the reason why a lot of people started to think about what can we do in terms of screening modalities to just make sure that we promote early detection and hopefully a better survival for lung cancer. And we won't go into detail of all the studies, but basically the studies started back in the 1970s with the Johns Hopkins Lung Project and the Memorial Sloan Kettering Lung Study. And so they accrued patients that had a heavy history of smoking, about 1 pack per day, and they randomized to either a single screening arm with X-ray or a dual screening arm with X-ray and sputum cytology every 4 months. Unfortunately, this trial didn't really show any benefit. There was similar mortality amongst both groups, but at least it just paved the way for other studies. And so in 2000s, the lung screening study, which is not this one, but they were the first study to assess the use of low-dose CT as a screening modality. It was kind of like a pilot study, and they found a benefit. They found greater rates of early detection, and so that study led to the National Lung Screening Trial, which is this one. This is the largest lung screening trial that was done, and they recruited 54,000 participants, and patients had to be 54 to 74 years of age at high risk for lung cancer, and this was at 33 centers in the US. And so they randomized 1-to-1 to either 3 annual screenings with low-dose CT or 3 annual screening with chest X-ray. And this study was pretty groundbreaking because they found greater incidences of lung cancer diagnosis with low-dose CT rather than X-ray. But more importantly, they found a 20% mortality reduction with low-dose CT than X-ray. And so in addition to that, the study also found an all-cause mortality decrease of 7% in patients in the CT group. And so I think one of the worries from the study and from just screening in general is the false positivity rate, right? That it was 96.4% for this in this study. And so that's one of the concerns that a lot of physicians have when it comes to lung cancer screening. But to keep in mind that we can see here is in the patients that were diagnosed by low-dose CT, up to 52% were diagnosed in stage 1A. And that's pretty significant because as we said earlier, stage 1A, the overall survival improved significantly from 6% at stage 4 to like over 60% at stage 1A. And so this other trial, the Nelson study, this was similar to the National Lung Screening Trial, but this was done in Europe. And so they randomized patients to either low-dose CT, but in this particular trial, the control group was just no screening. A little bit smaller, 13,000 participants, but pretty large nonetheless. And similar than the National Lung Screening Trial, they found a greater incidence of lung cancer with low-dose CT, and they found a better overall mortality reduction. And so similar again as the National Lung Screening Trial, they found in almost half of the patients that were diagnosed with screening, they were diagnosed with stage 1A. And for the patients that were diagnosed, non-screening detected, like we can see in the second row, 52% unsurprisingly diagnosed as stage 4. So again, the proof is in the pudding. And so finally, after these studies came out, organizations was like, okay, so I think maybe there might be a benefit to screening. And so the NCCN came out with the recommendations for screening guidelines in 2011, and they recommended screening adults 55 to 74, those that are current smokers or former smokers that quit within 15 years, and those with a 30-pack year history or greater than smoking. But they also included a Category B recommendations of those with a 20-pack greater of history of smoking and additional exposure that they defined as a personal history of malignancy, a history of COPD, a family history of lung cancer, or secondhand or other chemical exposure. USPSTF, on the other hand, was a little bit more rigid. In 2013, they recommended screening adults 55 to 80, current smokers or former smokers that quit within 15 years, and those with a 30-pack year or greater history of smoking. But recently, luckily in 2021, they updated their guidelines because they were realizing that we're leaving out patients that are high risk for lung cancer and they were not eligible for this criteria, mainly minority patients, African Americans, and women in general. And so they lowered their screening starting age from 55 to 50, and they lowered the pack year from 30 to 20. So great, we're moving forward, but maybe not as much as we would like to. And so here, just we can see on the left, which is the former guidelines, and it's 2021, the new established guidelines. And so what are the rates for screening update, right? So screening was implemented in 2015. It was approved by all insurances, commercial and Medicare, Medicaid in 2015. And so this is as of today, maybe like 2022. Screening national rates are 5.7%. Let that sink in, 5.7%. States like California has a screening uptake in eligible individuals of 1%. The best one that's doing is Massachusetts. Props to my colleagues there in Boston. And so, but in general, I would say pretty pathetic. And then how are we doing in Florida? Because obviously we're here, right? Even more pathetic. 3% is our screening rates in eligible patients. We're ranked at 40th among all states. So clearly below average, lots of work to be done. And so when I was a resident, it's when my love for lung cancer screening started. I was with my mentor back then, Dr. Ben Levy, who is probably, people know him in this group. And I was shadowing him, and I'm like asking him, like, why are your patients coming in with stage 4 diagnosis? Are they not being screened? It was a first-year residence, and this was in 2016. And he's like, not really. I don't rarely find patients that are diagnosed by a positive screening test. And so that led me to just wanted to inquire about our screening patterns in our institution in New York. And so I just wanted to understand our screening patterns and also just the physicians' attitudes and perspective when it respects to lung cancer screening implementation. And so I surveyed residents and attending physicians to understand what the barriers were. And a lot of them were not really sure which patients were eligible for screening. Some of them were concerned that the patients refused. A lot of them mentioned that they really didn't know what to do with the results. And I think that's a pretty valid concern. Many didn't know that the insurance companies cover or reimburse for these studies. And then some of them were just completely unaware that screening was even recommended. And so I decided to review our charts and see how we were doing, right? I reviewed 677 charts, so from patients seen from a 3-month period in 2016. The majority didn't even have complete data to be able to know which patients were eligible or not. And so I could only extrapolate those that had, which was 121 patients. And I found that from those patients, 62% met either criteria, and granted, this was the original criteria in 2011, 2013. Of those, only 27% had gone for low-dose CT. So again, pretty terrible. I'll talk more a little bit later as to what I did following up, but then in fellowship, I also wanted to understand, okay, so now I'm a lung fellow, so now let me see the patients that have a diagnosis of lung cancer, were they diagnosed by screening before if they had met eligibility criteria? And so I reviewed the patients that were diagnosed from 2016 to 2019. And so this is the patients that we reviewed, 530. Obviously, we only took into the smokers, which was 532 patients. And so we reviewed the charts. We found that 52% of these patients met NCCN eligibility prior to their diagnosis. However, only 4% of those had been undergone screening that ultimately led to a diagnosis of lung cancer. Similarly, of the patients that were reviewed, 35% met USPS criteria prior to diagnosis. Again, 4% had undergone low-dose CT. And so I wanted to understand and compare the stages, right, from the ones that were diagnosed by screening versus not. And the sample size was so small that we couldn't break it down by staging. So we can only do stages 1 through 3, so locally or local regional disease versus stage 4. And unsurprisingly, we found that the patients that had undergone screening were diagnosed at stages 1 to 3, versus about half of the patients that were diagnosed without screening were diagnosed at stage 4. So again, just reiterating what's out there in the literature. And so I wanted to see also, what about eligibility? From this analysis, I did a secondary analysis. Just let me see, like, is there any disparities in eligibility criteria? And so what we found is that Hispanic patients were a lot less eligible for cancer screening by USPSTF than non-Hispanic. And again, this was back before 2021 when the guidelines changed. And not only that, we saw that there was disparities and discrepancies even between screening criteria. So patients Hispanic origin were more likely to meet NCCN criteria rather than USPSTF criteria. And so I wanted to also understand, so for the patients that did undergo screening, who were they, right? Was there any disparities between the patients that had screening offered? And so, unsurprisingly for me, because I do a lot of my work in disparities in cancer care, majority of the patients that were screened were white. A small minority were African and American and Asian. What about female or men? So basically, of the patients that met NCCN eligibility and went for screening, only one female in that group, everyone else was men. And for the USPSTF eligible, everyone was men. No females were screened in that group. And then what about Hispanics, right? no Hispanics had gone for screening, and this is in New York. So this is something that basically, again, we have to do better. And so what are the barriers to screening, right? Because clearly the guidelines are there, the recommendations are there, but what's happening that we're not implementing it like everyone knows mammogram, most people get their mammogram, even colonoscopies, which is not that great, not that pleasant, and cervical cancer screening, they do much better than what we're doing. And so barriers, we said, lack of awareness, right? Unfamiliarity with the guidelines, access challenges. And then also barriers in terms of identifying eligible patients, managing abnormal results. And a huge concern for providers is also the exposure to radiation and the skepticism of the evidence. But let's look at these numbers here. The numbers needed to scan to prevent one death from lung cancer is 320. Compare this to breast cancer is 746. And colon cancer, granted, those numbers from colon cancer are old because I couldn't find new numbers, but 1,300 approximately. So again, the benefit is there, we'll really look into it. And so patients are concerned about, providers are concerned about false positivity, but what do we do with false positive? This is gonna lead to invasive testing. Patients are gonna get anxiety. What do we do about this? And so yeah, that's a valid concern, right? Because the false positivity rate is greater, about 20 to 25%. But when we look about the false positive biopsy rate, it's only 0.4 to 2.4. So still less than false positive biopsy rate for mammogram. And so what are the barriers when it comes to patients? Again, the fear of cancer diagnosis, the fear of cancer treatment of the unknown. In the past, patients were diagnosed with lung cancer, it was a death sentence. And so basically denial, fear of radiation exposure, and stigma and shame. There's a lot of stigma around smoking. I do head and neck cancer too. A lot of people are smokers and they feel terribly shameful, and it's just something that unfortunately patients feel the stigma around it. And so how can we overcome these barriers? So first thing is lung cancer screening program, right? This is the Sylvester Lung Cancer Screening Program. It's the first that was designated in South Florida. They have a closed system where we refer patients to our program, and then they follow up all the abnormal results, so then that doesn't fall on the provider. We have a nurse navigator that's designed to basically stay on top of all these patients and make sure that they don't fall off the wagon. And so what else can we do? So we liberalize the guidelines, right? And so I did another analysis of the patients that I had explored, and I wanted to see, okay, so these were the patients that met USPSTF 2013. How many would have met eligibility if the USPSTF 2021 guidelines were implemented? And clearly we saw that the rates were greater. Obviously we're gonna capture more people. But we know by now that not everyone that's eligible is getting screened. And so this was a study that I did as a follow-up to my initial study when I found the 27% rates of lung cancer screening in our institution. So I decided to do an educational program, right? And then after I analyzed the numbers pre and post. And so I compared the pre-intervention arm patients mainly that were documented in the system were patients that have a heavy history of smoking and that were current smokers. And then the post-intervention, we had 163 patients that have full documentation, again, mainly current smokers and heavy pack year history. So I think we're forgetting that former smokers are also eligible for cancer. And I found that after the intervention, which was an educational program that was provided over a 9 period of a month to attending physicians and resident physicians about screening, shared decision-making, all the studies and the importance of screening, our rates improved from significantly. And so we saw that from 27%, the rates of screening in eligible patients went up to 62%. And for some reason, a lot of the patients that were not meeting eligibility in the pre-intervention arm were undergoing screening, and those numbers also went down following the intervention. And so that's another way to overcome potential barriers. I think something that's also important is finding the people where they are, right? We have to take into consideration social determinants of health to be able to ensure that patients can go for screening. And I think outreach is a pretty powerful tool to reach these people and make sure that they're undergoing screening. How about screening in never smokers, right? Because we know that more and more people lately are getting screened, a lot of women, a lot of younger age. And so the talent study is a study that was conducted in Taiwan. This is not a great slide, so I'll move on. And basically, they recruited patients 55 to 75 that were never smokers and had at least one of the following risks that they define as a family history of lung cancer within 3rd degree, passive smoking exposure, TB or COPD, or a cooking index greater than 110, whatever that means, and not using a ventilator during cooking. They enrolled 12,000 subjects, and they found 17% of the patients had a positive scan. Interestingly, their lung cancer detection rate was 2.6%. So this is pretty interesting. And 96% of the patients were stage 0 or stage 1. And so let's compare this to the lung cancer detection rate that we saw at the National Lung Screening Trial is 1.1, and the Nelson trial was 0.9. So I think this is something that's worth reviewing. And so I think NYU tried to replicate the study also in the States, the FAN study. And so they recruited women ages 40 to 74 that were never smokers or smoked less than 100 cigarettes and were of Asian descent. 200 patients completed baseline, and 3% were diagnosed with cancer. And so their detection rate was 1.5%. And they showed that that's pretty promising, that it's feasible. And so I think something that in never smokers, it's still a lot of investigation and studies have to be done, but it's something to keep in mind as well as we try to even capture more people at high risk. And so what is the future for lung cancer screening? Artificial intelligence that's taking over the world, and ctDNA. And so our colleagues here at Dana-Farber are collaborating with MIT, and they created this Sybil algorithm. Basically, they used the low-dose CTs from the National Lung Screening Trial, MGH, and Chang-Gun Memorial. And basically, they're able to predict the future lung risk in a patient with a single low-dose CT. So I think that's pretty impressive and just helps personalize screening and try to avoid false positive and just find those patients that are greater risk. Similarly here, our colleagues at Johns Hopkins created this Delphi model. And basically they took patients on the left, the Lucas cohort was patients that were symptomatic at high risk for lung cancer. Of the 368 patients, 129 were diagnosed with lung cancer. They performed whole genome sequencing of the cell-free DNA, and basically they fragmented and understood just chromosomal changes, and they validated that method into a machine learning and basically created a model to predict cancer for that cohort. And then they did the same in an independent validation cohort, and basically this is how their model was born. I think our colleagues are doing a prospective study right now, and they're recruiting patients as of now. And so I think we've done a lot of work. I think a lot of work needs to be done. I think that we have a lot of room to grow, and hopefully we're able to get there. I'll take questions now.
Thank you. Any questions?
Thank you. That was so important. Also near to my heart as well. The stigma with smoking is real. So I have a question. I know we live in this EMR world. We're drowning in putting in data, and I wonder if we can use that to our advantage. And I often find that it's easy, mammograms is an age thing, colonoscopy is an age thing, cervical cancer for women. But because there's a couple of steps with the lung cancer, I find that, putting in the right information, required information for smoking, packs per day, and the calculation, I just feel it ought to be automated as right. The patient fits criteria, but it's just, we haven't taken that next step, which may really help primary care physicians who are boggled. I mean, they have 15 minutes, right? Like, are you going to do smoking cessation counseling?
The shared decision making.
Manage all the other diseases or try to calculate whether they fit criteria. So I wonder if we can hone in EMR capabilities into this.
Yeah, I think what we're doing currently at Sylvester is in the Epic, if the patients are like meet the age criteria and it says somewhere that they're smokers, an automatic referral like appears on the corner. The same with like if the patients are young and are gonna go for chemo, so the fertility preservation, it's kind of like automatic. But it is still like needed for the provider to sign off on it and make sure that you are on it. And then, so I think this is something that would probably be helpful for PCPs that are already overwhelmed. The alternative that they can do is just refer patients to the program and then have them just take care of it. So I think that's what we're hoping to do with Sylvester, right? Because it's a closed program. All you have to do is refer. You don't have to do the shared decision making. You don't really even have to see if they meet criteria. But obviously, this still needs an understanding and a discussion with the patient that this is going to get there. It should be universal. I just don't think we're there. But it sounds like a simple solution. So it's, yeah, I feel you.
Well, I'm a little horrified. Only 3% of patients in Florida are getting this screening that's indicated. And it sounds like there's an education gap, and you're working hard to decrease that gap. So do you think it's more important to target the physicians or the patients or both? Can patients self-refer? What's the strategy? How do we get more screening?
Yeah, so I think the way that we have to do is like almost like an all basis, right? Because there's barriers in every single step. Providers are not aware. So I think it's important, and we're trying to do that, just educate PCPs, and this is what's happening, even pulmonary doctors. My focus mainly is in reaching the patient. So what I'm trying to do is basically we have at Sylvester what's called like Scan 360, and so we can see the vulnerable populations and smokers and trends, and so basically go there, do the outreach, and ensure that we can facilitate screening. But then for them to be able to basically get enrolled and go through the program, they need to be insured, and we know that that's yet another barrier. And so I want to do, and this is an ideal world, but just see how much out-of-pocket costs. I think it's like we're doing it at $99. And so trying to get a grant just to be able to go out there to community centers, to get community health advisors and find those people, and if they can pay it, then cover it. Ideally in the future, we'll be able to get mobile low-dose CT. I think they've done it in some places. I think it's hard and they're very costly. But to your point, there's so much that needs to be done that it's hard to understand where to start. I think starting, in my mind, with the patients, telling them, do you know that this is even a thing? Like, do you know anyone that smokes? Bringing it up to your provider, right? Because if you show interest and you open the discussion with your provider, then there's greater chances that you're gonna get there. And using all sorts of social media platforms. My family are not in the medical field. They don't even know that this is a thing. So just trying to like educate even at the basic layers, hoping that it just disseminates throughout.
Excellent talk. Mark Jaluski from MCI here at University of Miami. I have two questions for you and one comment. In South Florida, it's really a cultural issue with the Hispanic population. I found it interesting that there were no Hispanics in any of the national trials, screening trials. Have you had a chance to look at your population and see if the data is as good as it is the national trials?
Yes, actually, Dr. Rodriguez, our colleague, did compare the rates of our screening with the National Lung Screening Trial, which the Hispanic population in the National Lung Screening Trial was 1.8%. Not an accurate representation of our population. Our population of obviously much greater, and our screening patterns were about 40% in Hispanics. And so doing a lot better. I think the barrier to that study that they found is that the patients would get a one-time scan and done. And obviously for the lung screening trial, they were able to get greater retention. And so, but that's my populational focus because I love screening and I love disparities. And so what I'm doing in my practice right now with the grant that I just got, I'm looking into hopefully understanding the barriers, the perceptives, and the attitudes to screening in the Hispanic population, mainly head and neck cancer survivors, and then facilitating education and screening for that population. Because I think a lot of it is we are misrepresented too in terms of the Hispanics are thought to be non-compliant or they don't care, but a lot of it is lost in translation, loss of language barrier, just feeling like we are like rat labs. And so I think cultural appropriateness, it's important, and I think that's what I'm hoping to do.
Well, some of the challenges that I've seen is that the family, the younger generation, don't want to tell the older generation that they actually have cancer.
Yeah, I can see that happening.
Even when you have a patient that has been diagnosed with cancer and you're offering them treatment, the family does not want you to tell the older patient. So it's a huge challenge to educate them enough to actually pursue screening studies.
Yeah, I can see that happening because they want to protect. I don't know, it's because maybe like they look like me, and so I'm able to just focus on the patient and kind of like have a good discussion and speak to their native language. That might kind of like help the course. I think trust is important, right? Like I feel like that's why we call about like diversity and inclusion, because patients trust the people that look like you. And so I think in that way I'm a little bit lucky, and I feel like I can get to them a little bit further than maybe some of my colleagues that don't share the same background.
Very nice talk. Thank you.
Thank you.
Thank you. Any last one more question before we go into the panel? Anyone? No? Okay. Thank you so much.
Yeah.